Good evening. I'm Michelle Leifer. I'm the director of the Usdan Institute for Animal Health Education at the Schwarzman Animal Medical Center. On behalf of my colleague Kimberly Young, I would like to thank you for joining us for tonight's event, Inflammatory Bowel Disease in Dogs and Cats with Dr. Douglas Palma. This webinar is for informational and educational purposes only and is not intended to substitute for professional veterinary medical advice, diagnosis, or treatment. If you have questions or concerns about your pet's health, it is always best to consult your veterinarian. Tonight's event will be recorded and we'll send out a link tomorrow in case you miss anything or would like to share it with a friend. We'll be taking questions via the chat box and we'll save some time at the end of the presentation to answer as many as possible. I'd like to take a brief moment to let everyone know about next month's event. It's on Thursday, February 22nd at 6 p.m. We'll host Dental Essentials, Practical Oral Care for Dogs and Cats with Dr. Ada Toe. You can find more information and register for that event on our website, amcny.org/events. We'll also have the link in our newsletter that goes out this evening. And now it is my pleasure to introduce tonight's speaker. Dr. Douglas Palma graduated from the Ohio State University College of Veterinary Medicine as class valedictorian. He completed both his rotating internship and his residency at the Animal Medical Center and was awarded his board certification in small animal internal medicine in 2008. Dr. Palma has remained at AMC, thankfully, practicing as a specialist in small animal internal medicine. He now heads up AMC's internal medicine service and is the director of the residency program, training residents in internal medicine. Dr. Palma has contributed to numerous scientific articles and authored multiple book chapters in internal medicine and interventional endoscopy. He has been recognized repeatedly for outstanding teaching and continues to contribute to ongoing clinical research. Dr. Palma has lectured at veterinary conferences throughout the country, and we are very grateful to have him with us to lead tonight's event. Please welcome Dr. Douglas Palma.
Good evening, guys. Thank you so much for attending. Hopefully, can shed some light on inflammatory bowel disease, the terminology that we use, and maybe give some perspective to where the profession hopefully is going in the future. And so, with that, I will share my screen. And okay, let me open my presentation. Okay, why is it not sharing? Hold on. One second. Can everyone see that on your end? You can. Okay.
Yes.
Okay. Perfect. So today we're going to be talking about largely inflammatory bowel disease, but in order to frame that conversation properly, we're kind of have to talk about chronic gastrointestinal disorders because they all kind of meld together, and it's important to kind of understand how we arrive at that quote unquote diagnosis and what it means when we say that, and where the differences are between humans and animals, and where we are going in the future. So with that, I just want to shed some light on what inflammatory bowel disease is in people. So in people, when you hear the term inflammatory bowel disease, we're generally talking about two main diseases, and that's not exclusive, but it's predominantly Crohn's disease and ulcerative colitis. And these are both, as the name would imply, chronic inflammatory disorders of either the small intestine or the colon, or the colon when it comes to ulcerative colitis. And with these conditions, they're not only confined to the bowel, they do have multi-systemic effects. So there are other organs that might be affected by this inflammatory state, but it's predominantly, as we think of it, at the GI tract level. And then there are other chronic inflammatory diseases of people, celiac being one of them, but other ones as well that are, by definition, chronic inflammatory conditions of the intestines. And so all of these get lumped in together as inflammatory bowel disease. So it's not a specific disease per se, but more of a descriptive term saying inflammation of the bowel. And that, of course, there are other disorders of the gut that are not inflammatory, that may be chronic and very much mimic these inflammatory disorders. So this is really the basis of human terminology. And when we look at dogs, we're not talking about ulcerative colitis or Crohn's. They don't get those conditions. We're talking about a chronic inflammatory condition of the bowel, more often than not small intestine, but can be large intestines. And it can be distributed unevenly throughout the intestines or diffusely throughout the intestines. It does not appear to be a multisystemic disorder. So we, to the best of our knowledge, we don't see joint involvement or rashes or anything of that nature. And, ulcerative colitis being one of the main forms in people, one would think that we see a population of ulcerative patients as well. We do, but it's not nearly as representative as it is on the human side. So there are some discrepancies there, but as the name would imply, inflammation of the intestines. And so that doesn't necessarily mean we're talking about the same condition per se. And so when let me hide this because I can't see my slide here because all your faces, your wonderful faces are covering it. Well, I'll just go from memory. So inflammatory bowel disease in people versus animals, even though the diseases are very different in what they look like microscopically, their distribution, their involvement outside of the intestines, we do believe that there might be shared pathogenesis or shared disease underlying predisposition towards disease, and it may be similar mechanisms, even though the characterization may be different in the species. What complicates this in veterinary medicine is we not only have we have different species. We have cats, we have dogs, and that's who I'm here to talk about. But we certainly see other breeds as well, other species as well. And then we also have breeds within that species. So a Doberman is not the same thing as a Yorkie and so on and so forth. And sometimes there are diseases that exist predominantly within one breed more than another. And then we have regional distribution where we have patients that are coming from the East Coast and the West Coast or other countries, and their predisposition towards certain types of infections that can cause inflammation may be very different. And so at the root cause, we believe that patients with inflammatory disease have an underlying genetic problem. And there is a genetic predisposition that either can affect both forms of the certain aspects of the immune system, whether it's the primitive form of the immune system called the innate immune system, or whether it's the more complex, nuanced form of the immune system called the adaptive immunity. Both of them may be affected, and there have been over 200 genetic defects looked at in people that have been associated with abnormal immune processing, if you will. And in addition to that, we have other factors that kind of pour fuel on the fire, if you will. So we have environmental factors. Smoking is a risk factor in people. We don't know so much in animals. And then we have things that may disrupt, or we may have disruptions of the intestinal barrier. So remember, our intestines are blocking bacteria and bad things that are inside the intestines from getting into our body. And sometimes that's just a physical barrier. Sometimes that is the immune system is a barrier. Sometimes it is the bacteria that live there that create a barrier. Sometimes it is chemicals or thing like mucus that's secreted that prevents the barrier from prevents things from getting in. So some patients may have an alteration in that barrier. And then in addition to that, we think, at least it's thought, that there are changes, or that the gut undergoes significant oxidative stress from normal metabolism, and that stress may be an added factor. And then there's alterations in blood flows as well. And as a result of all of these things, you can have an injury to your intestines with the right set of circumstances that results in chronic inflammation. And that, in addition to chronic inflammation, you can have further worsening of the local gene expression and potentially local bacteria that are present, so altered microbiome. So it's kind of the underlying pathogenesis, which we believe are similar amongst species, amongst diseases, is that there's this predisposing factor and multiple other factors playing a role. So, how do we define this disease or syndrome, if you will, in people? We define it clinically as patients that have chronic disorders for greater than 3 weeks. So, these are patients that are exhibiting one or more of the following symptoms for greater than 3 weeks: vomiting, diarrhea, or changes in stool volume. So, a massive increase in stool volume without a change in food might indicate that the intestines are not working well. Changes in appetite, whether that be a decreased appetite or actually an increased appetite, can be a manifestation of poor gut health. And weight loss, and because obviously in order to maintain weight, we need to be able to absorb our food. And as a result of the disease, we will have alterations in the function of the intestines, which might promote diarrhea, or alterations in the absorption of the gut, and changes in the motility of the intestines, or how they contract and move, and changes potentially in responses that might drive vomiting. So when the intestines aren't working right, it may send a signal to your brain that makes you feel nauseous and make you want to vomit. So all these things are what result in the symptoms that we see with inflammatory bowel disease. So the terminology starts to get a little dicey over the last few years, where we've started to resort to different terminology. So I'll introduce these things quickly. So we say chronic enteropathies, and chronic enteropathies just means diseases of the intestine. And these are things that are chronic in nature, so greater than 3 weeks, and they're diseases of the intestines, and they don't necessarily all mean that they are inflammatory, and they don't all mean that they are IBD in the sense that we were just talking about. So animals that have food responsive enteropathies, so they respond to diet. Animals that have antibiotic responsive enteropathies, that respond to antibiotics, and animals that have steroid responsive enteropathies or immune responsive enteropathies, which are kind of what we were talking about before, where the immune system's a little haywire, and we're trying to, and we need some immune drugs to dampen down that immune system. Much like we might need with asthma or with lupus or rheumatoid arthritis or anything else, we need to dampen down the inflammation. And then other things can get included in here as well. Chronic infectious diseases that are infecting the intestines could fall into the classification of an enteropathy, a disease of the intestine, or if they're inflammatory, under inflammatory bowel disease. So you'll notice that inflammatory bowel disease is a garbage can diagnosis, and some people refer to it as the patients that require steroids or immune drugs, and other people refer to it casually for patients that have a response to food or response to antibiotics and so on. So the terminology gets a little bit blurred at times. So with chronic large intestinal disease, these are kind of not as clearly labeled. So we have patients that have colitis, which means inflammation of the large intestine. Some of them are inflammatory, where we don't have an underlying cause, but they're inflamed. We have patients that respond to fiber, and they aren't necessarily inflammatory, but they respond to fiber supplementation. We have patients that also have antibiotic responsive diseases. And then specifically when we're talking about the colon, we have certain types of infections that can be very chronic diseases. And there's something called histiocytic colitis or granulomatous colitis. And then we have a term that I threw in here called stress colitis, because a lot of us may be familiar with this term being used casually. We don't quite understand what this means, but we do see a population of animals that get large intestinal symptoms when stressed, and we don't really know what it means yet, but we casually use that term. And so then those are those conditions, but then there are other things that create chronic intestinal symptoms that are not inflammatory per se, or are not not the ones that we included. And that would be certain forms of cancer. Certain forms of cancer can cause chronic intestinal signs, parasitism of the intestines, abnormalities in the structure of the intestines, where we might have a foreign body that's been wedged in there for some time, or in intussusception, where one piece of the bowel kind of gets telescoped into the other piece of the bowel, or strictures or adhesions. So there's a lot of things that can cause symptoms, and we need to sort out that it's not these things that we're talking about, but it is the other inflammatory conditions that are chronic. So we use a myriad of tests to kind of figure out that this is not tumors and that this is not a foreign body or something like that. And then to make it more confusing, we even can go outside of the intestine, right? We don't just have the intestine is not the is can be a target organ of something outside of the intestine. So you can have certain disorders that affect the endocrine system that can cause vomiting or diarrhea or weight loss or some of the same symptoms. And so a condition called Addison's disease or hyperthyroidism or kidney disease can make us vomit, not eat, lose weight. Certain types of toxins or medications we're administering, liver disease, pancreatitis. These are things that are outside of the gut that can actually affect gut health. And you can see how it gets a little confusing how we hone in on a diagnosis. We need to exclude all of these other things to arrive at the diagnosis. So we'll talk about what I think of when I think of inflammatory bowel disease. I think of patients that require steroids, patients that have an underlying predisposition towards inflammation, and they do not respond to diet or other interventions, antibiotics, fiber, what have you. And so I will call this group steroid responsive enteropathies or immune responsive enteropathies, and also casually called idiopathic, meaning we don't know why it happens, inflammatory bowel disease. And how do we make that diagnosis? We have to have a compatible history, meaning they have to have the symptoms for greater than 3 weeks, and they have to have compatible symptoms, vomiting, diarrhea, weight loss, changes in appetite. They need to have compatible biopsies. So we need to actually take biopsies to show that there is chronic inflammation there. We need to exclude all the other things that could mimic this in their presentation. And then we need to have shown that just because there's inflammation there, that inflammation was not responsive to diet or antibiotics or other things. And so it's these criteria that lead to the diagnosis. So it's not just the biopsy, it's not just the symptoms, it's a whole bunch of things put together to lead to that diagnosis. And so again, this population, we believe, are predisposed to inflammation. They're born with presumably genetic abnormalities that predispose them to inflammation. And that is partially that they have an alteration on how they interact with the bacteria that are in your intestines. So normally we have bacteria in our intestines and in our colons, and we're constantly communicating with them. And we don't want to attack them because we don't want to create inflammation in our own intestines. And so how do we do that? We have a very nuanced system where bacteria are interacting with us at the microscopic level. And when they interact, your body says, this is a friend, this is not an enemy. And some of these patients have alterations in how they perceive normal bacteria. And so they perceive normal bacteria as the enemy. And that could be through a bunch of different mechanisms. Or like we talked about before, a bunch of different alterations in immune function. They could have immune cells that are upregulated. They can have immune cells that are normally supposed to quiet everything down. They can have reduced function. So there's less cells quieting everything down, so everything is upregulated. So it's very complex, it's very nuanced, and we don't exactly know within a given population what exactly is driving it, except to say that something is affecting our immune function. And so we have these patients that have a predisposition for inflammation, but then there are other things that may trigger this population. So the analogy I would use is a patient with asthma. It has a chronic predisposition towards inflammation in the airway. But what if someone was smoking? What if someone was spraying perfume? Those things can trigger the asthma and make it worse. And so while this population may not respond to diet, because by definition they don't respond to diet, what happens when the intestine gets inflamed? So normally we have diet and we have bacteria, and they don't create inflammation. They don't get through the wall. They don't get through the intestines. They sit on the inside, and you have a barrier that works. But with IBD, they may trigger inflammation, and that may recruit these inflammatory cells which come in. And when these inflammatory cells come in, they make the intestines leaky. And when they make them leaky, the bacteria and the food, they can get deeper into the wall of the intestine. And when they get deeper into the wall of the intestine, it induces more inflammation. And so you can see how a patient who's predisposed may have this amplification with certain diet substances and certain bacteria that can contribute. So then we'll step off of that population and we'll go to the other patient population. We see this food responsive enteropathy. And you'll notice how we don't use the word allergy, because there are a lot of things about food that are not just allergens. So it's not just allergies, and not everyone has inflammatory changes. Not some of them have. You may have disturbances in your intestinal function or your symptoms that aren't driven by inflammation. So we just call it food responsive enteropathy, or food responsive disease of the intestine. And it's not that simple. It's not simple at all, because diet is very complex. Every time we switch the diet, we are switching the antigens, or the triggers of the immune system. And those can be proteins, those can be carbohydrates, those could be things that we are adding to the diets that just to make them preserved, for that matter. So a lot of things. Every time we switch it, we switch these things. We switch how much fiber's in there. We switch what type of fiber's in there. And that can have a tremendous impact on gut health. We switch how much fat is in there. And fat sometimes can exacerbate certain types of GI disease. We switch how much this food is digestible. And the less something is digestible, the more it may promote diarrhea. We affect our bacteria that are there, because what do the bacteria eat? They eat what we eat. And when we change our diet, we change the populations of bacteria. We call that population, that group of bacteria, we call it the microbiome. So we change that. We also change the consistency of the food, which in some patients, not so much for this, that may play a big role in whether or not they're regurgitating usually. So the other thing is there's not necessarily one diet that's going to fix every patient. We do have certain diets that we may select for, but there's not necessarily one diet per se that's going to always be far superior to another, and it's complicated. What are the common diet trials that I think about? That, if I have to categorize these millions of diets that are out there, what constitutes a diet trial to me? So I have diets that are highly digestible and low in fat. And these are the typical things that we always said, get some boiled chicken and rice and feed them. We have what are called hydrolyzed diets, which are basically really, really low reactive diets. We have hypoallergenic diets, or what we call novel protein diets, where we give something like kangaroo, where something our immune system's never seen before. We have diets that are high in fiber. And occasionally we have patients that, flunk all of these things, but respond to unusual diets. And so, what I can say is that if you practice medicine enough and you do enough medicine with patients with chronic gastrointestinal disease, you will find that there is a patient that responds to just about every diet. And there's a patient that does poor on a diet, and there's a patient that does fantastic on the same diet. And so what worked for one patient may not work for the other, but we do have some generalizations that work for the masses. It only becomes confusing when we don't respond to what works for the masses. And there are many commercial diets that are out there. It don't always have to be veterinary diets. The only concern we have with some of them is that the quality control in eliminating potential inflammatory proteins might be lower. So for instance, in one study, they found up to 50% of the diets said they were only giving venison, but they would find other proteins in that food as well. And so it's not so we stick with veterinary diets when we can because they tend to have a little bit more quality control over those things. So then what do we do? How do we treat these? How do we test these patients with food? We give them food for 2 to 4 weeks, and we evaluate if they respond. And we are going to see do their symptoms go away or not. And in a fantasy world, we would put them on the diet and they would get better. And then we would re-challenge them to the old diet and we would prove that they have an allergy. But we don't generally do that. We generally put them on the diet and we say they're better and we say they're better from the diet. And, there's a lot of effort, or there has been a lot of effort to try and find tests that can reproduce this reliably. Unfortunately, there's testing where you can draw blood and see are we allergic to chicken? There's testing where you can actually do kind of intradermal testing, like a dermatologist would do. And then there's testing where you can actually use saliva to look at. And none of these have really shown to be reliable. So you may find that you react to certain proteins, but that doesn't mean that you don't tolerate them and vice versa. So it is, unfortunately, we don't have a good test except to feed a patient the food and see what happens. And to move on away from food responsive disease, we move into these infectious diseases. And, fortunately for us in Manhattan, we don't have a lot of these infectious diseases, but we do see them from time to time, so we can't get lazy. We have to remember that patients can have infections and they can mimic a disease that might require steroids, and we definitely don't want to give these patients steroids. And so some of them have fungal infections, some of them have weird fungal infections called zygomyces, some of them have algae infections, some of them have mycobacterial infections, not quite like TB, but kind of like TB. So there's a lot of infections that can occur and they can mimic inflammatory bowel disease. And what helps me to decide whether or not I think a patient has one of these may be geography, where they're from, the patient's age, what organ systems are affected other than the intestines. These are the things that kind of lead me to think this doesn't look like a patient who has the classic steroid responsive disease, but this looks like a patient who could have infection. And then we think about viral things. So you think about viral things, certainly dogs get a lot of viruses. The vast majority of them are, and cats get a lot of viruses. The vast majority of these viruses are not chronic. So we're not going to typically have a chronic viral infection that's going to mimic inflammatory bowel disease. Once in a blue moon in the cats, we will have patients that have FIP, which is a coronavirus. I know it's the dreaded word coronavirus. It's a different type of coronavirus. Or every once in a while, feline leukemia. But those are the exceptions to the rule. As a general rule of thumb, our patients do not have chronic disease with viruses, with a few exceptions. And then we have all these parasites. There's all these parasites, and we got whipworms, and we got hookworms, and we have Giardia, and we sometimes have something that we see in cats called Trichomonas fetus. All the ones in red are the ones that cause disease with some frequency, depending on where you are geographically. So we always have to remember that this could be a parasitic infection, and we may need to make sure that we deworm them before we give them steroids or do anything. So we're doing our due diligence. We're making sure that we don't have parasites, that we're not responsive to food, and so on. And then we say, well, what about bacteria? Again, bacteria, the vast majority of patients who have bacteria have acute diseases similar to viruses. Now, there are rare circumstances where certain bacteria can cause a chronic condition. And in this list, the condition that we see with high frequency is something called histiocytic ulcerative colitis, which occurs from an E. coli, and it occurs almost exclusively in boxer dogs and French bulldogs. So it used to be called boxer colitis. And so that is actually caused by an E. coli. It's a genetic abnormality that predisposes them to this infection. And that is a chronic condition. But the vast majority of them are acute. So when I see a patient with chronic disease, I'm usually, unless it's a boxer or a French bulldog, I'm usually looking not for infection, unless I'm looking for one of those weird infections and it has the geographic suggestion that it might be present. And then the other thing that is just complicated is that these organisms don't always cause disease. They can be there and they don't cause disease. How many people walk around with MRSA in their nose? Lots of people. They're carriers of it. And so you can have carriers of Clostridium. You can have carriers of Campylobacter. You can have carriers of C. difficile. These are organisms that can live in your intestines and cause no harm. And so when we test patients for these things, we may get a positive. And it doesn't always mean that they are actually sick from that. And so it gets very confusing sometimes because there are lots of fancy tests that are out there that will document these now. But we always have to go back to it. Is it just an association? Is it just there because it was always there? Or is it causing disease? And this is where our job gets a little bit difficult. So it's complicated, but they rarely don't. And then we say, well, what else about bacteria? Is bacteria itself rarely are driving it's not like one type of bacteria is causing disease. That's pretty uncommon. But bacteria are immense. They're super important. They're probably one of the most important things, and we're in our infancy of understanding them. When we think about our intestines, they're filled with bacteria. We call it the microbiome. The microbiome is all the bacteria in our intestines. And we know a little bit about this over the last 10 to 15 years, but it's complicated. There's billions of bacteria that are there, and they're all working together. And as a result of them working together, your intestines work better, and systemically, you are better. Certain diseases have been associated with abnormalities of your intestines that are far removed from the intestines: schizophrenia, obesity. There are things where the gut flora, the gut bacteria are actually not only affecting the intestinal health, but are actually affecting systemic health too. And this is influenced by age, this is influenced by diet, and we're just in our infancy of understanding. We talk about the microbiome, we talk about the bacteria in the gut, but it's even way more complicated than that. There's viruses. There's actually tons of viruses in your intestines. And these viruses are also playing a role too. And then there's fungi that live in your intestines. And all these things are working together to make you function make your gut function the best. And there's a lot of interest in this every day, more and more interest about the gut health, the gut bacteria, the gut viruses, the gut fungi that are leading to good health and bad health. And so in disease, particularly in these patients with inflammatory disease, it's not uncommon to have what we call a dysbiosis. And a dysbiosis is just a disrupted bacterial flora. And it may be when we get inflammation, it can disrupt the flora. When the flora becomes disrupted, it can cause disease. So it is an amplifier. So not only can you have disrupted flora causing disease, you can have disruptive flora from disease. And you can see how this dysbiosis or altered bacteria can drive more inflammation. And so to look at this kind of pictorially, we've got trillions of organisms, trillions. We've got we have the microbiome, we have the virome, we have the mycobiome, and trillions of organisms working together and operating together to help the gut to work and that. So it's very, 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 very complicated. So we're not alone. We're far from alone. And what do these bacteria do? They help protect us against bad bacteria. So they provide a barrier. They secrete things that kill other bacteria. They take the nourishment from the intestines and maybe take it away from bad bacteria. So they protect us. They provide nutrients. They secrete things that we can absorb that we need in our gut. They aid in digestion and absorption of material. They are important for providing this barrier, this super important barrier that protects us from not only the bacteria, but the proteins that are in our intestines and anything else in the intestines that we don't want in our bloodstream, that we don't want to piss off our immune system. And it helps to stimulate the intestinal development of growing patients, and it helps to manipulate the immune system. So it's interacting with our immune system, and it's quieting it down, or it's upregulating us in a way that we are just in our infancy of understanding. and hopefully in a way that in the future we'll be able to manipulate with some degree of comfort. And so these bacteria aren't just there. They secrete things, they make things, they do things. They make something called short chain fatty acids, and these provide energy to our colon. They are super important in energy metabolism. They have anti-inflammatory properties. And so these are just some of the things that have been studied a little bit more in veterinary medicine that contribute to disease or contribute to pathology. And so it's super complicated. So not only are the bacteria potentially affected, but what they make that we depend on are affected. And so then we're going to step away from just the role of bacteria, and we're going to step into this group of disorders that we call antibiotic responsive enteropathies. And so, as the name would imply, they were disease of the intestine that is responsive to antibiotics, and it gets a little confusing. And we don't usually use this term in we don't usually use antibiotics in animals that have acute disease. There's a lot of data now that says that giving a patient metronidazole in the emergency room is no better than doing a lot of other things. And so we try to avoid giving antibiotics because those antibiotics can sometimes really screw up our microbiome. And we're really worried about the microbiome these days. So we don't want to screw it up. We don't want to contribute to disease. And we don't know what that does to us long term. Does it affect our systemic health? Do we get cancer more? We don't know. And so it's better not to mess with it, not mess with things you don't understand. And so when we're talking about patients that have chronic gastrointestinal disease, there is a population that does respond to antibiotics. And it's not surprising that they may not have an infection that you could put your finger on. You may not be able to say, this patient has salmonella and we're going to treat the salmonella. But it's very easy to understand how trillions of bacteria working together to help your gut to function could get screwed up, and antibiotics may help them to be less screwed up. And so it makes some rational sense that you can have a response to antibiotics that's not necessarily measurable with with a test or a culture or something like that. And it gets confusing because there's lots of terms used in veterinary medicine. There used to be small intestinal bacterial overgrowth, and there was something called antibiotic responsive diarrhea. Then we've got something called tylosin responsive diarrhea, which is a specific antibiotic. And now we're kind of going back to the word dysbiosis. And we don't really know. Are these all the same disease? Don't really know. I think until we know more, it's hard to really say what we're doing. But to look at the bacteria in patients that have inflammatory disease, so not a direct infection, we've been able to study that a little bit better. And we know that dogs and cats that have alterations in their bacterial flora, that have inflammatory bowel disease, have a screwed up flora. They have a less diverse flora, and they have certain types of bacteria that are increased and certain types of bacteria that are decreased, and certain alterations in the metabolites that they make. And so we know this, and we can study this, and we can use this as a test to say, yes, the gut flora is screwed up, which sometimes we do to be academic, and sometimes we don't because the clinical utility is, in my opinion, sometimes questionable. And so this is just to kind of re-emphasize that point, because many of us in this room are very familiar with going to the emergency room with a pet that's sick, that's having diarrhea, and getting antibiotics. We're trying to get away from that. We really are trying to get away from that because we are studying the gut, and we're realizing how bad we screw up the flora. We don't really know what that does to us. And what we haven't been able to show reliably right now is that it works better. It feels like it works better. It always felt like it works better. But the more and more studies we do, the less it's convincingly working better. And so it makes us all feel better when we give metronidazole in the emergency room. But the reality is now there's been 7 good studies that haven't really documented a superiority. I still am convinced it helps in some of them, but it hasn't been proven yet. And so we don't want to screw up the flora. We don't want to create antibiotic resistance. And there are certainly times where it seems like it improves things, or and conventional wisdom means that I've been doing this for 20 years. I believe it helps in some patients. And I think the people who've been doing this for a long time would argue that there is a population that needs it, but en masse, it doesn't. And so when you go to the emergency room and you get a diet or you get something else, just realize that you're not necessarily getting a disservice. And so just because we're talking about antibiotics, there are some controversial things that are not controversial things, but the things that are kind of hot topics in veterinary medicine right now is use of antibiotics in acute disease, because it really can screw up the flora. It can create this dysbiosis of the flora, and it might be sustained for months and months and months after you do it. So you may think you're doing good, but you're actually screwing up the flora for months, and and that may create dysfunction not only in the intestine but maybe outside of the intestines. And it's not effective, like I said. So there's been some head-to-head studies looking at metronidazole compared to probiotics or compared to just a bland diet, and they haven't shown superiority. So I just, not that we're talking about acute diarrhea, but put it in here because we're all familiar with, many of us who have pets for any extended period of time have heard flagyl or metronidazole at some point in time. And many of us have it in our household right now. So there are some limitations to this kind of this new way of thinking. Is that what about the patients that have chronic intestinal disease? There is a population that seems to benefit from antibiotics, so it's not just all or nothing. It's not that there are times when we use them too, and it makes sense that we could use them because we know that the bacteria gets screwed up. We know there's a lot of bacteria, and we know that bacteria is promoting inflammation sometimes. So if we manipulate that bacteria, we might be able to reduce inflammation. So it makes some sense. And so the current thinking is don't use them, but I think that some of us that have been doing it for a while still think that there's an application for them, but we do use it with a little bit more respect for the gut health, and not as cavalierly as we might have had done in the past. And so then we're going to step into, okay, well, it makes sense to use antibiotics. What about these probiotics? Everybody wants to use probiotics. Probiotics do a lot of things. They can generate these short chain fatty acids that have so many good benefits to the gut. They can induce these defense proteins made by the intestines. They improve the gut barrier. They help to promote the production of antibacterial properties, or antibacterial secretory products that might help, might control bad bacteria, if you will. They help to manipulate the immune system. They may quiet it down, or they may upregulate it, in the ways that we want. And they may help to improve ingestion. These are things that have all been shown kind of experimentally. And so they have all these great potential benefits. And the reality is that we know a couple things. We know the intestinal bacteria is super important to our gut health and systemic health. No debates about that anymore. We cannot debate it. And we know that probiotics, when we take them out and we study them, we can find all these good benefits. The principle is sound. We know that in our patients that have intestinal disease, we can document dysbiosis, and it's there. It's screwed up, so there's a reason to want to use it. The problem is that it's complicated. We're talking about trillions of bacteria working together, and we like to oversimplify it. We want to use something benign. We want to use probiotics. We don't want to give steroids. We don't want to give antibiotics. We don't want to do anything. We want to give probiotics. And the problem is it's a simplification, and we're not at a point yet where we have the best understanding of how to manipulate this system, or what the best probiotic is, or when you give it and when you don't give it, and should it get combined with other things. We just don't know yet. And so there's a lot of my probiotics better than your probiotics talk, and I want to try this probiotic, and my mom's on this probiotic, but it's really complicated, and I hope that one day we understand it a little bit better. And there's not really great evidence for one over another. There are some that I think work a little bit better, that have some data, but in a lot of these patients, they're not the panacea. They do not result in avoidance of steroids or avoidance of anti-inflammatory drugs. And then we have this concept of prebiotics, and prebiotics are basically the food that we feed to ourselves feeds our intestines. And these ingredients are fermented by the bacteria that are there. And when they're fermented, they'll result in changes. And they either result in changes in the numbers of bacteria that are present, or the activity of bacteria that are present. It may not even affect who's there, but it may affect how they're behaving. And so it's food that impacts the gut health and your health as a result of it. And what we use very frequently is fiber. Fiber is by definition undigestible. It goes in your mouth and out your butt. And on the way through, it does a lot of things. Your bacteria eat it and and your bacteria produce things from it. And some of those things are super beneficial. But we talk about fiber because it's easy. It's something we can give. It's something we can add. It's something we can kind of measure. But fiber is complicated. There are different types of fiber, and they do different types of things, and not all of them are the same. And then there's other things that have a prebiotic effect that have been studied that sometimes get added to dog foods or cat foods, fructooligosaccharides. And no one knows what that is, but it gets added to food because it's a prebiotic and it helps to have it confer a benefit to the patients that are eating that food. And there's a lot of them, and we don't have this good source of prebiotics right now that we use readily, but there's a lot of experimental evidence showing lots of different substances that exert an effect on the bacteria that are there and ultimately the health of the intestines. And in the future, hopefully we know the optimal prebiotics to use and when to use them. And again, like I said, it's not always that it's manipulating the bacteria that are there to change the who's there, but it's sometimes to change how they operate. And so, there's lots of fiber sources. And, I use a lot of psyllium powder in patients that have fiber responsive disease. And these are the doses I use, but they're. And then we have the ultimate probiotic, which is the fecal transplant, or when we're trying to be fancy, we call it the fecal microbiota transfer. And this is obviously something that's been around forever, for a long time, but became very trendy in people with C. difficile infections, where we found that, hey, if you give poop from your friend and you have a C. difficile infection, you have a 95% cure rate, whereas vancomycin didn't do that. And so it's now standard of care. And that is the ultimate prebiotic. And so we do use this in patients that have diarrhea. And we don't know the right time to use it, but I do find that as a whole, it tends to be better for patients that are not really sick. The really sick patients probably need a little bit of everything. It's rare that we can give them a fecal transplant and they resolve. And so it's something that people come to me about and they want me to do it. And I'm not opposed to doing it. You can understand the principle. But I'm not going, in general, it's not going to usually respond in those tricky cases. Those early cases, those low-grade inflammatory cases with diarrhea, they may respond beautifully to it. And so just to kind of put this pictorially, each one of these represents a different type of bacteria. You got the antibiotics, they come in and kill a whole bunch of bacteria. And as a result of killing them, other bacteria grow up and we change the population. So that's one way that antibiotics could help or potentially hurt the gut, right? They change the flora. Then you've got the probiotics, where we add a whole bunch of probiotics, new bacteria. And after we add them, it selectively manipulates the flora to get rid of other ones. And now you have more of one and less of another. Even though we didn't kill the other, they outcompeted them. They changed the system enough that you could maybe select for healthier gut. Then we've got these prebiotics, and with the prebiotics, we add some food. You'll see the little hamburgers over there, and the green guys like the food. They go over and they eat them, and they're eating the food. And as a result of eating the food, they change the flora, and they alter the flora, but just by secreting things or growing or replicating as a result of having this energy source. Or what happens is you get the food, and they're eating the food. And remember, sometimes they might secrete things. They might secrete these things, and they might actually secrete things that affect your intestines. So that's how prebiotics work. Remember, so it's not always that they change who's there, but sometimes it changes the things that they're secreting. And that could be super important because some of those things are what determines disease or no disease. And then we have FMT, or fecal microbiota transfer. We just say, okay, we're just going to add a ton of bacteria, all different types of bacteria from a normal, healthy donor. And as a result, it's going to outperform some and you're going to change the population. So that's kind of how we think about manipulating the microbiota or manipulating the bacteria and ultimately manipulating in a way that maybe reduces inflammation systemically and or locally within the intestines. And so moving on from the theoretical and all that stuff, we'll move into kind of just the more clinical stuff. How do we sort all this junk out? So what do I think, like when I'm a clinician and I got a case in front of me? First thing I want to know, is this acute or is this chronic? By definition, chronic diseases could be an inflammatory bowel disease. It could be an infectious disease. So is it acute or chronic? If it's acute, it's going to have a different list than if it's chronic. And then I'm going to talk about, where are they? Are they in Louisiana? If they're in Louisiana, I'm going to be thinking about certain types of infectious disease. If they're in the Ohio River Valley, I'm going to be thinking about different infectious diseases. Whereas if they're in the middle of Manhattan in an apartment on the 60th floor, I'm not thinking about infectious diseases. And then I'm going to think about, what's the breed? Is this a Frenchie? If Frenchies get boxer colitis, if you will. Is this Yorkie? Yorkies get really significant intestinal disease. So there, I'm going to have my biases based on what the breed is, what the age is, what's the sex potentially, what the species is. And then I'm going to look at how progressive or non-progressive are the symptoms. Has this been going on for 4 years and it's never changed? If it's been going on for 4 years and it's never changed, we probably don't have cancer. We probably don't have an infectious disease. And immediately, I'm going to not be wanting to necessarily do more tests. I'm going to be wanting to fix the problem, and I'm going to want to make sure that we do the things that we want to do before we consider doing more tests. And that would be, do they respond to diet? Do they respond to antibiotics? Do they respond to fiber? It's not that complicated when you look at the algorithm. If they're really progressive and they're getting sicker by the day, and last month they had diarrhea once, and then the day after it was twice, and then it was 10 times, and now it's every second, that patient probably we need to make sure that they don't have something really bad, and we need to look there. So we pay attention to this information. We use this information to tell us what tests we want to do. And that's important for you and your own health and your health of your pets, is when you go to see your doctor, these are the things that you want to convey to them. You want to convey, how long has it been going on? How progressive has it been? Is it something you've always been living with? Is it episodic? Is it getting worse? These are the things that are going to help your doctor hone in on the problems. And so it's not specific to gastrointestinal disease, it's specific to just being a doctor. But for me, for intestinal disease, obviously it has its own algorithm, if you will. And sometimes we look at, certain things that make us really worried that we're missing, that we need to consider looking deeper. And so if they have really dramatic signs, if they're just super, super sick, and we can't just put them on a diet and send them home. If they've lost 50% of their body weight, if they are not eating at all, if they have blood work changes that show that their proteins are low, if they have such bad gastrointestinal disease that their proteins are so low that they can't hold the fluid that's supposed to be in your blood vessels, and it starts leaking places, then we better be looking for bad diseases. We better be doing more than just sending them home with a diet. And then if they have disease outside the intestines, remember, we said most of our patients with inflammatory bowel disease do not have disease outside the intestines. So if they have disease outside the intestines, we have to say, is there another thing like an infectious disease or cancer we should be worried about? And then we say, okay, well, we got the history, and then we want to make sure that they don't have any parasites, because that's something that nobody wants to do all these things and then find that you missed whipworms. And then if it's appropriate, if they're from the right geographic location, if they have the right history, if they have the right exam, we may test them for certain things. Then we might do some basic blood work. And, unfortunately, blood work isn't always all that helpful. Many times blood work doesn't give us the answer. People say to me all the time, they said, how is it possible that my pet has cancer? And the blood work was normal. And unfortunately, that's true not infrequently. And so the same is true with GI disease. We look for certain things that may suggest bad GI disease, or may suggest that it's not just the intestines that are affected, but is rarely diagnostic. It's rarely diagnostic. And then sometimes we do some fancy tests. We check them to make sure that they don't have Addison's disease. We check their cortisol levels. We may check to see if they're absorbing certain things, the B12 or the cobalamin or folic acid or folate. We might check to see if they're absorbing them, not only because that tells us that the gut's not working, but it also tells us that we might need to supplement some of these things. And then, in the age of tests, there are a whole bunch of blood tests that we can do that kind of suggest an immune response to the intestines, and some of these are out there. And again, where we use them clinically, I don't know where the best way to use them clinically is, but they've been shown to be elevated in patients with inflammatory bowel disease, but sometimes with food and sometimes with ones that don't respond to food. So it doesn't really tell you the best way to treat the patient in front of you. It just says there's chronic inflammation, essentially. So don't use them as much, but they're out there and you may see them somewhere. Someone may suggest doing them. And then there's tests that look at the pancreas. We say, is this a pancreatic disease that's masquerading as intestinal disease? And we might do some tests there. So there's a lot of tests that we might do, but we don't always do them. We do them when we think we need to do them. Like any good doctor, we shouldn't just sign up $1 billion of tests. We should find the ones that we think are actually relevant to our patient, and we should do them when we need to do them. And then we have imaging. We have ultrasounds and we've got x-rays, and we could do fancy things like CT scans. But usually in veterinary medicine, we rely for these types of diseases on ultrasound. And ultrasound is a good screening test. It tells you whether or not there's something grossly abnormal, but sometimes it's normal. So there's pitfalls to an ultrasound. You can do an ultrasound and it could be normal and you could have very significant intestinal disease. So this imaging might help us to point us in the right direction, and it might help us to rule out bad things, obstructions, a foreign body that's stuck in there. Those sort of things will help to be ruled out with an ultrasound, but it can't definitively rule out inflammatory bowel disease because you can have a normal ultrasound. So you got to remember the pitfalls with these ultrasounds, but we do them frequently to help rule out other things, but but they're not perfect. And then ultimately, we've done all these tests, and we say, I think this is a patient who hasn't responded to diet and hasn't responded to fiber and hasn't responded to all the diet trials I want to try. Maybe it's time to put a camera in and do endoscopy. And you might put a camera in and do endoscopy and make sure that there's not an infection and confirm that there's inflammation. And then that's how you make your diagnosis. And sometimes we talk about surgical biopsies, but most of the time endoscopy. And so again, what do we have in our armamentum to treat these patients? How do we make them better? We have dietary trials. We have the ability to manipulate the microbiome, whether that be through antibiotics or probiotics or prebiotics or a fecal transplant. We have anti-inflammatory medications sometimes for colitis we'll use a local non-steroidal medication like sulfasalazine, or we use immunosuppressive drugs like prednisone or cyclosporin or some of these aggressive immunosuppressive drugs. And then we have medications that just are trying to keep us happy and healthy and not feel sick, control nausea, control our appetite while we're trying to get the disease under control. And then for patients that might have a low B12 or cobalamin or a low folate, we might supplement them because not only are they caused by the disease, sometimes they contribute to the disease, so we might need to treat them. And then everyone always says, well, why steroids? Why do I have to use steroids? I hate steroids. Well, nobody likes steroids. Nobody wants to use steroids, but many people are on steroids. We just want to make sure that when we use them, we know we have to use them. And when we use them, we don't use them in a cavalier way. And we try to minimize how long they're on them and the doses that we do. And so why steroids, though? Because we know this is an inflammatory condition. And we know that inflammation causes disease. And addressing it will be helpful. And it has great evidence to support that it works. And it's a reliable medication. And because veterinary medicine is not nearly as good as human medicine at predicting exactly what part of the immune system is disrupted, so you can pick a very specific drug, we use drugs that all have a wide effect, and steroids have the broadest effect on the immune system. They're the most anti-inflammatory, and we don't have the same data in animals. In fact, we have contradictory data that a lot of the drugs they use in people wouldn't work in animals because, for instance, something called TNF blockers TNF is we'll just call it a hormone that's elevated in people, but it's not elevated in dogs and cats, so it wouldn't work in our population. And so we use steroids because they're the most effective. And sometimes sometimes we have to use other drugs, but they're not as reliable. And so then our goals, what are my goals? My goals are to shut down the inflammation that's causing the dysfunction of the intestine, restore the gut barrier so that the gut can protect itself and minimize inflammation, resolve the symptoms that you guys observe, and then minimize the side effects of medications. And you got to keep in mind that not all cases are easy, and some of these cases do not respond to treatment. You know, there's been a term that's been coined lately called a non-responsive enteropathy, and it's been reported up to 15 to 43% of animals will have a non-responsive disease. I think that's very high. I would say it's probably more in the 10 camp for me, but that's the numbers that are out there. So some patients don't respond, and that shouldn't come as a surprise for any of us who know someone with a chronic disease. Not everything is easy. So then, like I said, we use steroids, but if the steroids don't work, sometimes we need to do other things. We need to use other immunosuppressive drugs or other chemo type drugs or other non-steroidal drugs. And maybe there's the application for stem cells or an application for radiation therapy, things that we don't do a lot of, but have been looked at and may have value. And so it's also important that it's not just one thing sometimes. Sometimes we got to manipulate the diet. And if we just do the diet and we just manipulate the diet, we fail. And if we just use anti-inflammatories, we fail. And if we just manipulate the microbiome, we fail. But if we do everything in concert, then we have success. And that's the important thing of being able to think about it as a system with a million inputs that are driving inflammation and disrupting the flora and interacting with the host, that we need to find the right nuanced approach to the outcome, which is success, right? And so what are our future goals? Our future goals are to hopefully define the disease system or find a way that we can say, this is a dog and this dog is reacting to the intestines and they're doing it in this way. And as a result of doing it in this way, we have a specific molecule that will target that we can block. And that in people, fortunate for them, they have very specific responses. People with Crohn's disease, people with ulcerative colitis, their immune system reacts in a specific way. And it's not a specific way for dogs and cats. And because of that, the drugs that they use that are super specific, because they work across a wide group of people, they don't work for us. And so I would hope that in the future we can find targets that we know, that we can study, that we can measure their blood or look at their intestines and say, this patient will respond to this drug. Or use drugs that prevent the white blood cells from getting to the intestines. In people, they have these drugs. Or drugs that help to reestablish the barrier function. So there are these proteins that hold the cells together. They hold them together. And that holding of them together can sometimes can be manipulated in the future to keep them closer together so they maintain a barrier. And maybe in the future, targeted probiotics, ones that are resistant to being dissolved in the intestines or have the optimal anti-inflammatory effects, or that maximize our prebiotics. So we're in our infancy, and we probably will continue to be there. But it is an exciting time in human and veterinary medicine with all the information we're learning about the gut. But you can see the complexity, and you can see how it's probably going to take a long time to sort it out. So with that, I will take any questions that you have if I haven't confused you all.
No, thank you so much. I know it's a complicated topic and you did a great job explaining it. So thank you for this great presentation. We have a few questions we'll go through.
Of course.
So we have a question just about probiotics. Should probiotics be used only when needed? Can extended use of probiotics cause dysbiosis?
It's a great question. I think that we don't have data on extended use of probiotics, but most of the probiotics that are out there have exerted some theoretical beneficial effect to the gut host. So they may cause a restoration of normal gut health, if you will. So I don't think they will ever cause a dysbiosis in a pathologic way. they're going to disrupt the flora in a way that might be beneficial. Can they be used chronically? Absolutely. They, like I said before, there are all sorts of diseases that are associated with disruptions of flora and maybe influenced by that. And, I hope that one day in our lifetimes, or maybe our granddaughters' lifetimes, that we will be able to say, if we take a probiotic, we live longer. If we take a probiotic, we get less cancer. If we take a probiotic, we don't get type 2 diabetes anymore. We just don't have that data, but I believe that it's important. So it's hard to collect all this data, but the short answer is no, I don't think it creates any adverse effects.
Okay, great. Are there any foods that people should avoid if their pet has this issue? We also, many people asked about carrageenan, so if you had any thoughts on that, but just
Yeah,
generally
I
any
mean,
food.
yeah, I mean, I think there are. I think that's the thing that people want to latch on to all the time. A food substance, a food component that is as universally bad or universally good. And the reality is it's just not that complicated. I think when you start to look into the complexity of this, you start to understand that our ability to understand that it's just the corn, it's got to be the corn. It's got to be this, it's got to be that. That's beneficial. It's so simplistic and narrow-minded that I don't think you can generalize. Like I said, there are certain diets that I implement because I think that they en masse do better than other diets. But I have absolutely had clients say, listen, we're not responding. We're in that non-responder category where um, they put them on a raw food diet or put them on a diet that I would not have necessarily condoned, but it worked. And so it just goes to show you that we don't understand as a profession. And when we get these rigid stances, when we say this diet's better than that diet, it's better than that diet, and I put my friend on this diet and he got better, so therefore you should do it, you're doing a disservice to the profession and to our evolution of knowledge. You create this tribalism over your camp. And
Mm.
the reality is that there's a population out there that's going to do better with your diet and worse with your diet. And we just oversimplify it because we have had experiences. And I hope we get away from that. And I try to not judge a diet because I've been burned
Mhm.
on people putting them on diets that aren't supposed to work but do work when I'm failing. So I've been humbled in that regard.
Okay, great. We had a question about the hydrolyzed diet. Why does protein, it's still there's still a problem with protein even on
Yeah.
that diet?
Yeah, so on those diets, I mean, they're so basically what they are is you take a protein and you rip it up and it gets closer to amino acids. It's not quite amino acids. The immune system recognizes, let's say, chicken as chicken when it looks like chicken. It has to be a certain size, it has to look a certain way. It's a very nuanced system. The immune system targets things that look a specific way. Otherwise, it would be reacting to everything and you wouldn't be able to live in the world. And so when you take chicken and you make it smaller and closer to amino acids, it's more at its base level, its building blocks, and the immune system can't recognize it as foreign. So depending on how hydrolyzed it is, how small the molecules are, that will depend to some degree on whether or not your immune system can react to it or will react to it. So the more hydrolyzed it is, theoretically, the less antigenic it is, the less pro-inflammatory it is. So in children, it's not infrequent to use elemental diets. And elemental diets are one step further. They are essentially amino acids. So if you have a child that's having raging diarrhea, um, and they will put them on an elemental diet because they know that that is not going to trigger the immune system. It's going to be very, very absorbable. And when the intestines calm down, they're going to start to implement one protein after another protein and figure out what we can get away with. So you can still react to them. They're not perfect because they're not all completely hydrolyzed to the lowest component, but they certainly are in the way the immune system recognizes things. They don't look like their target and they're not weighty enough, meaning the molecular weight, to trigger an immune response.
Okay. Okay. Yeah. Let's see. We have a few people asking about Pepsid and if
Yeah.
that can be used. I know it's
Yeah, I mean, Pepsi can absolutely be used, and I think for lots of disorders, there may be some benefit to using Pepsi. So, there's been a reinterest in looking at use of H2 blockers or proton pump inhibitors in patients with chronic or acute GI disease. And we as a profession have certainly tried to kind of standardize along the lines of humans or where it's appropriate to use them or not appropriate to use them. And there are criteria that we try to adhere to, but they're certainly benign for the most part. They can interfere with drugs. Some of these interfere with the metabolism of other drugs. So we just take these things and we don't realize that it might interfere with how well another drug might be absorbed. So there are drug interactions. But apart from that, they're generally pretty safe. Now, there are certain conditions that I use a lot of Pepsid or Prilosec, if you will. Those drugs, might be for patients that have esophagitis or reflux, right? Patients that have ulcers in the stomach. Um, Patients that are predisposed to ulcers in the stomach, I might want to prevent them. Patients that are on non-steroidal anti-inflammatories, I might want to use it. So I do use them a lot. For patients that have vomiting from inflammatory bowel disease, they're not typically that effective because they're not really anti-vomiting medications. They're just blocking the acid. But I do think there are certain diseases that very much respond. My own personal dog has a condition called bilious vomiting syndrome, and he vomits in the mornings. And probably a bunch of people on here have dogs that vomit in the morning, and that responds to acid suppressive drugs. So there are roles for them and their use for them, but as a general rule of thumb, for the patient with an inflammatory process in the gut, it's not your first drug of choice.
okay, great. Can Giardia in a young dog lead to IBD?
Yeah, so there has been some work specifically with parvovirus and some other models that have shown that inflammation at an early age can lead to an increased risk of IBD. And so parvo, another
Mhm.
condition called acute hemorrhagic diarrhea syndrome, when you follow these patients out over time, they've been shown to have an increased um, percentage of compared to the generic population or risk factors, if you will, for developing IBD. And so early in life or maybe later in life, insult to the gut can cause either a dysbiosis or prime them for inflammation in the future. So it's a very good question. We don't know specifically about Giardia per se, but we'll learn more about that, but it makes very rational sense. I don't see it as a common association, but it makes rational sense for sure.
Okay. And are fecal tests effective and reliable for detecting parasites?
Yeah, so they're not because not all parasites will shed eggs at the same time, or you might
Mhm.
get them in what's called the pre-patent period, the period before they're actually shedding parasites. So there are newer fecal tests that look at PCRs. So they're kind of like, looking for the DNA, if you will, of the parasites. Those are way more sensitive, meaning that they detect a lot more that wouldn't be detected by routine fecal screening. But in general, it's always a good idea to use a broad spectrum dewormer in a patient that has symptoms compatible with GI parasitism. In Manhattan, we get a little bit lazy because some
Mhm.
of our patients never leave their arms of their
Mhm.
owners, and they might be on very effective preventative medications. But if you go to Texas, for instance, there are a large number of dogs with chronic gastrointestinal disease from parasitism, and if you didn't empirically treat them, you would end up doing colonoscopies on patients and seeing worms, and nobody ever wants to do that. We want to treat them before we ever do a colonoscopy and find worms, right? So yeah, they're not reliable 100%.
Okay. And how often should a puppy recheck who has this and is stabilized and doing well?
Yeah, so I mean, I think a lot of the time, when I see a patient, I might just say, contact me back and tell me how you're doing. I made an intervention and I want to know how they do. And sometimes their exam is not that impressive. They may vomit 3 times a week, but it doesn't mean that their physical exam is that abnormal. And so it depends on the case. It depends on what I'm tracking. And you can tell me more effectively than my physical exam can tell me on how you're doing because it's going to be based on how often we vomit. What's our weight doing? Are we increasing weight or are we not? So in patients where I'm tracking something, maybe the intestines were really thick and the lymph nodes were really large, and I want to make sure that they're normalizing. I might get them back in to relook at imaging, but honestly, it's based on symptoms, and at some point in time, I want to check them back. Now, if they're on immunosuppressive drugs, if they're on medications that require some form of monitoring because of toxicity, I might have them in sooner. So Leukeran or chlorambucil is a medication I would want to check their bone marrow and make sure it's working okay. And so there are certain medications that have a specific regimen, if you will, follow up, but it's really dependent on the case. I don't I'm just as happy to receive an email and save you money than I am to get you in and have the same conversation I can do with 2 words on an email. Good job
Okay.
on an email.
All right, this is a broad question, but is there anything in a young puppy or kitten that you can do to prevent this? So,
Yeah, I mean, nothing that we know of, but certainly probiotics would make a lot of sense. I would say indiscriminate use of antibiotics certainly would make a lot of sense. Routine deworming, following an appropriate deworming strategy to prevent us from getting inflammatory responses. I'm still thinking about your Giardia question because even though there's no data on Giardia driving it, I do see fairly reasonable number of animals that come to me having had Giardia early in life that are developing chronic symptoms. So young animals, and they're still young animals with chronic symptoms. So I do see them. It's just not reported, but I absolutely see them where the Giardia is not driving the symptoms anymore. So the more I think about it, but yeah, nothing that you can easily prevent. Just making sure that you protect that gut barrier and that you don't do things to indiscriminately just add antibiotics or just affect it in a way. Certainly, things just for routine management, switching the diet, things that quickly, they're probably not going to predispose you to IBD, but they might promote diarrhea. Yeah, nothing specific. One
okay.
day, maybe I hope to say antioxidants and probiotics, and you'll be fine. But we're not there yet. Certainly not wrong to do.
Okay. Well, it seems like you've come pretty far in the past few years, or I know there's a long way to go. But anyway, thank you so much. Everyone's saying wonderful lecture and how they learned so much. It is a frustrating topic, someone's saying. But I really appreciate this. Dr. Palma, this was, fantastic. And thank you again for
Well,
taking the time to
I
join us
appreciate
tonight. Yeah.
I
Um,
appreciate the opportunity. I think it's obviously something I see and deal with every day, and I just want you to kind of get an understanding of the complexity of it and the terminology. And it's important to note that while I tried to lay out the terminology in a way that would be academically appropriate, not everyone uses the terminology appropriately. So where I use it in the quote unquote right way, it may get bastardized in all sorts of fashions in lots of places. So this is the way we should be thinking about it. So we're all talking the same language, but it doesn't necessarily mean that we all think about it the same way either, unfortunately. So
Great.
hopefully we'll get better on that front.
Well, that makes a lot of sense. And thank you very much. Okay, thank you everyone for joining us tonight. Just a reminder that next month's webinar, February 22nd, is Dental Essentials, and we will send out the email tonight where you can register for that. Again, Dr. Palma, this was wonderful. Many people saying thank you and how you've really helped their pet so much. And just thank you all for joining us. I really appreciate you spending part of your evening with us. And thank you. We'll see you next time. Take care. Bye-bye.
Thank you. Bye.